treatment, autologous chondrocyte implantation. So I'll change it slightly because it fit in the acronym better. We're calling this STACi now. So there we go. What we're going to talk about today is why do we need to do single treatment ACI? What are the cell pathway, and is it actually effective? And what is the evolution of autologous chondrocyte implantation or cell therapy? And we're going to talk about a clinical case that I have done as well. So to start off, this is the cell pathway of the osteoarthritis and about bone healing, fracture healing. It's very, very complicated, and also we not fully understand how the body heals itself, and it's extremely complicated. The principle that we have talked about before in my previous lecture is about how we're going to regenerate the body. We have talked about how do we change mechanics in my last lecture. We have talked about the growth factors, and we have talked about the scaffold. And today we're going to focus on cells and how can we get the cells and where we can get the cells from. So let's go straight to it. Where can we get the cells from? So we can get it from our skin, we can get it from our bloodstream. So we did a little lectures about platelet-rich plasma beforehand, and also we can get it from our bone marrow, which is a very common place that a lot of people try to take what we call stem cell from. I'm going to talk about the use of stem cell, the word stem cell. Is it appropriate? Is it what we should be doing later on in the session? Of course, we can also get cells from the placenta, we can get it from the umbilical cord, or we can get it from the amniotic fluid, or even get it from the unborn baby. This is not something that I'm going to talk about because it relates to a lot of ethical issues. So I don't think we should get cells from there. And of course, the other thing that we had a lecture beforehand, we can get cells from the fat. And what I think a couple of months ago we had a lecture on the magic of fat cells, and that we can use the fat to do something. However, if we want to grow cartilage, what do we need to do? All these cells that we have doesn't really grow cartilage. The one that I just talked about. There are only two cells we know in the humankind in the world that can actually form cartilage, and these are the stem cells. So when we talk about stem cells, are the cells that will differentiate and multiply into anything that we want. The other thing is cartilage cell. So cartilage cell is a cells that designed specifically to produce cartilage, and we call them chondrocytes. And so these are the two things that we know that can potentially produce cartilage, human hyaline cartilage. So first of all, let's, as I talked about earlier on, we're going to talk about stem cells. Let's have a little look at stem cells and what does that mean, and is this term appropriate? So here's a diagram of what the stem cells pathways look like. Mainly there's two pathways. One is the hematopoietic stem cell pathway, which means that these stem cells will form blood cells, so they form the white blood cells, the red blood cell, as well as platelet. And the other lineage of the stem cells they will form is what we call mesenchymal stem cells. These are the cells that will form the other stuff. What is the other stuff? So cartilage is one of them, bone, fibrous tissue, fat, and muscle, and skin, and nerves. We did talked about this last time when I was talking in the lecture of fat cells, but again, I just want to bring that to our attention. And this is the side that we want to focus on, the mesenchymal stem cell side. Because the hematopoietic stem cell side, if you get any cells in the blood, they will just form blood cells. It will not form the other stuff that we're interested in, especially not cartilage. So where do we get mesenchymal stem cells from as compared to the hematopoietic stem cells? Mesenchymal stem cell, we typically in the textbook and from all the medical literature that is getting from the bone marrow. So these are what we're looking at, the hematopoietic stem cell, the mesenchymal stem cells, and that's where we typically get them from. There you go. So let's go back to it. So I used before to show you about the different a mesenchymal stem down. So mesenchymal stem cell at the top, and we can form bone at the bottom. But actually, what we're interested in this time is only the cartilage side. So we can see the mesenchymal stem cells, and then they will form chondrocyte, and then the chondrocyte will maturate, and then they will produce cartilage. And that is the only side that we're interested in. Now, this is what the cartilage surface look like. I want to bring your attention to the top layer. There's articular surface layer. In the middle, there's our chondrocyte, our cartilage cells. And a really important structure in there is something called the tie mark, which is the mark here, which is the tie mark. And that is the layer that separates between the bone, which is at the bottom, compared to the top, which is the cartilage. So this is the structure of a cartilage. This is what a cartilage looks like when we're doing regenerative medicine. When we are trying to rebuild what we got in our body, we need to respect that structure. So let's talk about mesenchymal stem cells. So what a lot of the time on the literature is called MSC. So what is mesenchymal stem cell? Why do we call it mesenchymal stem cells? The reason that we have that term is because it was discovered and was described by a professor called Professor Arnold Kaplan. He had written a paper about the diagram I showed you before, how stem cell could multiply into different sites, and there's the two lineage of stem cells. This technology, so he worked in the lab, he's a very clever chap. He worked in the lab and he made up this assumption in 1988, and he published an article, a paper on this differentiation in 1994. Now, if you really think about it, that's great, that have formed a lot of scientific basis of what we're doing today. But the more interesting fact is, if you think about it, these hypotheses formed back in 1988. It was almost 30 years ago. So basically, when they're looking at these cells, when they're assuming these cells, they're using a technology that is 30 years old to look at how cells differentiate and how things work. So it is not quite accurate to what we can see things today. Technology had moved on, and the way that we can look at cells, the way that we can look at our evidence, things have changed, have moved on. So really, this is the term of mesenchymal stem cell is a outdated term. And actually, Professor Arnold Kaplan have recognized that, and he recently have published a paper to urge us not to call these mesenchymal stem cells anymore. These cells should be termed medicinal signaling cells, because in the lab, back in those days, he can turn these cells into whatever lineage that he wanted to be, but actually in the human it's very difficult, and there hasn't been much proof that these mesenchymal stem cells can actually turn themselves into cartilage. However, with the technology that we have now, we know more about what these cells are doing. We actually knowing that these cells are actually signaling cells. They are more like a manager, more like a director, to actually tell the other cells what to do. So I'm just going to give you a very simple analogy. The term of mesenchymal stem cell, MSC, was discovered with a computer that's 30 years old, compared to the computer we have now, which is very, very different. So therefore, we need to keep our mind open and think about what these cells are doing. And I want to show you this paper here. This is a paper written by Arnold Kaplan, who is the chap that initially described the stem cells. He actually tells us to stop calling these cells stem cells, because he thinks it's misleading, and we must not call them mesenchymal stem cells anymore. They are medicinal signaling cells. So that's his lecture, and that's we take a photo. He said, please, this is what we need to change our terminology to. What we think these MSC does is medicinal signaling cells. So a really quick way to think about it, they are basically a large drugstore for the body. So these cells will guide and release growth factors to the neighboring cells and wherever environment they're in, to direct the cells to do repair, to do regeneration. So next thing we're going to talk about, so we put the stem cell, park them aside, so we know that we shouldn't really call them stem cell. We can call them MSC or signaling cells. It's fine. The other things that we know that we produce cartilage is the cartilage cells, as I talked about. There's no dispute about that. the cells that in the cartilage will produce cartilage cell, and we call them chondrocytes. Now, has there been any research, has there been any study on chondrocytes? Yes, there is. There has been a long history of what we're trying to get the cells in the cartilage and grow them in the lab and put them back in the place, usually is in the knee because it's easily accessible, to regrow these cartilage. And there are many papers, many long-term outcomes to suggest that autologous chondrocyte implantation is very successful. So this is something that I want to talk about again. Every time I want to talk about chondrocyte, I need to bring in my mentor, Professor James Richardson from Oswestry, whom had talk about this, who had taught this to me, and we have been working together. And these are the paper that I want to show you about the autologous chondrocyte implantation. There's very good long-term outcome. There's two papers from the American Journal of Sport Medicine. They both produce good outcome for ACIs. So in the UK, we have actually made it work as well, and so this is the hospital that has a longer history of using ACI, and we've got over 20 years data with Professor Richardson, and it works very well. I no longer work there, but the next thing I want to talk about is in the UK there is a body called the National Institute for Health and Care Excellence. So what this body is looking at the evidence to see, is it appropriate, is it reasonable, is it cost effective for the national body to recommend this treatment for everybody, because in the UK with the National Health Service people do not have to pay. So they really scrutinize these evidence, and in October 2017 they have said that yep, it is appropriate for people, not for everybody, for people that have a large damage, more than 2 centimeters square in the knee. We can use this technique to help them. Now this is very important, because if there is no strong evidence, NICE will not recommend that. For example, I can give you an example that platelet-rich plasma, PRP, recently there is 10 randomized control trial, level 1 study to say that PRP have a good benefit to knee osteoarthritis. However, NICE still not recommending it, even with 10 positive randomized control trial. So you can see the evidence that NICE require is much, is very, very strong. And if NICE approve it, that means there's good evidence out there in the UK. Now, let's quickly talk about what is ACI, autologous chondrocyte implantation. So this is just a very brief summary. So what we do is we find a lesion in the knee, we get some cells from the knee, we then take them off, digest them, grow them in the lab, expand them, and then we put it back into the defect, and we put something over it and wait for it to grow, and it will heal itself. Now, ACI is not new, as I said earlier on. There is over 20 years of experience, and there are many different generations also. So I found this really good diagram that actually summarizes all these 3 generations. This is generation 1 of autologous chondrocyte implantation. As we look at the cartilage structure before, what we need to do is we just need to put a bit of cells at the bottom. We then, on the top, we stitch it over with a periosteal patch. So because back in those days, there's no fancy 3D printed scaffold or any synthetic material. So this is the first generation and how people do autologous chondrocyte implantation. And there is a study that published saying there's a very good long 20 years result with first generation of ACI, and that's what first generation is. Then they come to the second generation of ACI, and this is second generation. So what we tend to do is our technology have moved on. So instead of using a periosteal patch, because periosteum is not designed for cartilage, it's more designed for bone. But in generation 1, there's no material available, so therefore we have to use that. But on generation 2, there are some off-the-shelf ready synthetic material that made specifically for this. So we actually we were able to impregnate the cells into this scaffold, and we put that scaffold in. And sometimes we call this technique MACI, M-A-C-I, so matrix-assisted autologous chondrocyte implantation. With this technique, in theory, that will make more biological sense. The cells are already impregnated on it, so it should give a better outcome. And then we got third generation, what we call, so third generation, the difference between second and third generation is these extra bits of triangle, the little bit of green triangle. This green triangle represent growth factors. So we know that, so that's actually come more to that restoration principle that I put in earlier on. Instead of giving them cells, giving them scaffold, we need to start giving them nutrients as well. So these are the growth factors. So we integrate this together to build this scaffold. And with this third generation, we're mixing cells with sometimes with PRP, sometimes with bone marrow aspirate concentrate to help to produce these, to give them some indication, some growth factors, some nutrients to help the cell to grow. So these are the third. This is the third generation of scaffold of ACI. As you can see, between the three different generations, the difference really are in the way that we hosting these cells. So really, it's in the scaffold itself. The technique of culturing the cells or moving the cells has not really changed much, and that is something that is I'm going to talk about in later on in the lecture, which is something that we need to is quite important. But here you go. Traditionally, these are the three generations of ACI, and there we are. So then you may ask, okay, you have all these different generations, generation 1, 2, 3, which one is better? So I found this really interesting paper to say basically that there's no conclusion to say which one is better than the other. We think they are better. We think it make better sense to do it that way, but actually it probably is the same because the number is not big enough to see which is better. But the really important thing is that they conclude that the two-stage procedure is very costly because we have to take the cells out, we have to send it to a lab, process it, culture it, and come back to have another operation. This is a long process, and it takes 2 weeks in between in the interval, and some may argue that only take 1 week in different labs, but still, it's 2 operations. It does take time. The cells have to leave theater to go to somewhere to be cultured, and then they have to come back. So there is a lot of potential error. Of course, we can monitor the process. We can put ISO standard on these process and try to quality control them. However, there will be potentially can have human error, and as much as we try to standardize things, it may not be possible to completely standardize everything. So it's something that what prompted me to think about, well, actually, is there anything else out there? And also think about why our different technique doesn't make any different generation of ACI doesn't make too much of a difference. I mean, in theory, it should, because we got a better membrane, better. We think is better. It's more akin to what the cartilage structure are. So in theory, that should produce better results. But then that made me think, why does it make better? How about we focus a lot of the cell membrane and we focus a lot of the scaffold. How about the actual cells itself? How about the way that we culture these cells, or how about the way that we process these cells? Is that important? Surely that's the most important part, because if when you're growing you're growing a lawn, planting some seed on the grass. For the grass, you want to make sure you choose the best one. The one that is going to survive, and the one that will give you the best quality. But then there are so many different techniques of cell culturing, and there's no one standardized way to do it. How do we know this is the best way forward? We don't really. And sometimes some of the people, when they do microfracture, they do it with when they do it with ACI, they do it in combination with microfracture. And does that actually make any sense? I will talk about microfracture in a little bit and see does it actually make any sense, and why do we do it. So I think one of the best way to do is, let's go back to basic and think about what are we trying to achieve here to regrow these cells and regrow the area. So I don't want to flash the same slide again. It's about the principle of regeneration medicine, but we're focusing on the cells. So let's go back to basics. What we need to understand, what is cartilage? How can we see the different type of cartilage, and how can we define it? First of all, let's define cartilage. The best way to define cartilage is quickly do a internet search. So I found that on Wikipedia, and on that it basically, so this is a definition from just pull straight off Wikipedia. Cartilage is a cells that is elastic, it got hyaline cartilage or fibrocartilage. But the important part here is cartilage does not contain any blood vessel, any nerves, and its nutrition supply is actually come to the chondrocyte by diffusion. So the key here is there's no blood supply, there is no nerves. So now for the audience, I want to challenge you. If you're orthopedic surgeons, I would challenge you next time when you try to do a microfracture, what are you trying to achieve? So here we go. Here is a microfracture. So this is a very common procedure. We make a few holes into the defect area, and then the beliefs and what is say in the literature on the textbook is that by having these making these drill holes or making these puncture hole, blood will leak out, or stem cells, or that's what we believe, will leak out from these holes, and then these stem cells will form cartilage. Now, we are talking about already the dogma of stem cells. We know that's not true already. So the next thing is, let's give you the benefit of the doubt and say that yes, it's true. Stem cell is there and it definitely grows. Now, I can tell you that from the lab, what we do is that when we take the bone marrow aspirate from the iliac crest, which will have a lot more cell count than these few little holes. By doing that, only 0.01% of these cells are of stem cell nature, of stem cell genic nature. So if I taking 60 ml of bone marrow aspirate from the iliac crest, I don't even get 0.6 ml of stem cells. And that is in a lab condition, in culture. How are we puncturing a few holes? We get the stem cell coming out. I don't understand it. The more important thing I want to bring it to your attention is that, remember, when we read on Wikipedia, it say that cartilage cells do not contain blood vessel. So why are we trying to get blood into the cartilage? Now, this is a slide that I want to show you about microfracture. That's typically what happens with microfracture. We all know fracture does not heal with cartilage. Fracture heal with bone. So this is how microfracture heal. And there is some new device out there. They say that you can do nano fractures because it's smaller than micro, so they use the word nano. But there you go. Bone heal with bone. The body only know how to do one thing. So I do, want you to think about it next time when you're trying to do a microfracture. What are you trying to achieve? And actually, when you're breaking bone, when you're making those holes, the stem cells are not coming out. What's coming out are these guys. These are osteocytes, osteoclasts, and osteoblasts. We know from our fracture days that this is how bone heal. So there shouldn't be any difference in nearer the joint. The other thing is this diagram I'm always going back to is that top surface is the cartilage, bottom surface is the bone, and this is the tie mark. This is what our creator give us to separate between the bone and the cartilage. So do not go around and breaking that. It does not make any logical sense. So here is my bit of microfracture and about the blood supply to the chondrocyte, which does not need any. They do not need any blood supply. That's not how they work. So let's go back to the chondrocyte itself. Let's go back to the cells itself. So we talk about these cells. They don't, we see them, and there's no blood in it. So the environment that they like to live in is somewhere that without blood. So where did these cells live in? They live in something called extracellular matrix. So what is in the extracellular matrix? So you can see these cells in there. There's this white cocoon. That is the extracellular matrix. So therefore, let's look at what is actually these cells want. What environment does these cells actually want before for them to survive, for them to flourish? It's not blood. So this is extracellular matrix. So what is in this extracellular matrix is three things. So they need collagen, they need proteoglycans, so such as your hyaluronan, and they also need glycoprotein, and they need to maintain in a good pH balance for these cells to grow. And these are the stuff, the foundation that the cells want to build themselves on, and that's how they will grow, how they will flourish. So if we're going to design a way that we're going to grow cells, how shall we do it? So we need good cells in order for this cell therapy to work. So how can we get good cells? Where can we get good cells? What is the best cells? Of course, the best cells is the cells from your own. So we have to get it autologous, your own self, instead of get it from other people, because you have a chance of rejection, chance for disease transmission, and chance for gene transmission. So the best thing to do is get your own cells if you can, and they also have been lived. They lived in the same environment, so we want to use the same cells nearby. Where can we get them? So bone marrow, we can get some of them, but actually, really, we are really interested in the chondrocyte, and to get the chondrocyte, we can only get that from the cartilage. Next thing is the scaffold. So what scaffold we want to use? We have talked about we should not use blood, so we should not make those holes and make them bleed, and make sure it doesn't bleed. That's very important. We need to make so they like to live in a collagen-rich and hyaluron-rich environment, so they need to be there. And also, we need to make sure they got growth factors and stimulation around it. What should we use for growth factors and stimulation? What we can use is platelet-rich plasma that contains some growth factors, and that contains some we can sometimes mix it with hyaluron as well to give them the nutrition they need. So we know all these stuff, how cartilage survive, but in practice, we don't apply to it. We will apply this to it, which I urge you, please do not. So the next thing to do is, once we get our cells sorted, okay, let's say we can get the nice cells environment, the next thing to do is, how can we make them grow? So how to make cells grow? It's called culturing. So culturing, why do we culture them? Because we want to expand the cells, we want to have more numbers, and surely more numbers is good. But is it? If you speak to the scientists, if you look at all the literature, nobody knows what is the minimum number of cells required for ACI to work. There is lots of study compared to the different quantity or amount of cells for the cells to work, and there's no difference between the smallest quantity to the biggest quantity. So it is something that very interesting, and I think that we need to challenge our thinking and go back to the beginning and say, actually, do we actually need the culture? And if you remember what I said earlier on, the expensive part for these is the culture part, and the two-stage part that's expensive. So let's say, can we actually take the culture out of the equation? And actually, what does the culture actually do to these cells? So here we go, cultures. So when we culture cells, we take the cells out, we digest them, and we put them in this really nice pink material, and that's how we grow, and that's how we grow stuff in the lab. And there are lots of stuff we put in this pink fluid. So there's something called DMEM. So and within that DMEM, there's so much chemical, there's so much stuff in it, and also we add in fetal calf serum sometimes. So these are the serum coming from cows. And as you know, if you're working in a lab like me, you will know that sometimes with this batch of fetal calf serum, the cells will grow. With a different batch, the cell will not grow. So really, that's not very scientific at all, is it? It's not very quality control and we also use in other animals and cells, or the tissue fluid to actually grow our cells. And also all these other stuff that we put in, try to keep the cell concentration, make sure they grow within and set the pH correctly. It's not something that I think there's a lot. So therefore, with these growth culture medium, it probably will affect the cells. And then the next thing to do is, after the culture medium, what do we do? How do we culture the cells? We grow them in an incubator, of course. So this is a very smart incubator. The manufacturer told me that they got lots of monitor within this incubator. We can monitor the oxygen level, we can monitor the carbon dioxide level, nitrogen level, humidity, temperature. Great. However, is that the right environment for our cells to grow? Because if you look at the incubator, all incubator is grow cells in air, warm, and give them the carbon dioxide. But as I told you before, if you look at the cartilage cell, the cartilage cells do not need blood supply. Therefore, they do not really need oxygen that much. And we actually put them into compared to what they used to, this is an oxygen-rich environment. So this is not what they want to do. And I know we're monitoring these 5 things, but actually we may need to monitor things a little bit more. We need to monitor the pH. We need to load them. There's a lot more things than just monitor these few things. So for me, when I work in the lab, when I first grow cells, if you grow them into passage 1, passage 2, passage 3, and you multiply them. But when you first put your cells in, when you first take it out from the human body, when you digest and you put them in, this is what they look like. But by the time you grow them to passage 9, you have put them into this oxygen-rich environment. You have then put this pain chemical in them, so that will affect them. By the time this ninth generation, they probably look something like that. That is completely different to what you have before. And we now putting these cells back into the human body and expect them to form cartilage. I don't know. I think there evidence say that they still do some, which human body is very resilient, and I think that, but that's not ideal. So can we do better? Can we treat our cells better instead of give them in a very unfriendly environment and culture them and make them grow, make them reproduce, and then we use them afterwards? Well, let's try. Let's see, can we do better? So don't forget, on the regenerative principle, the most important, we have to make sure we take care of all four. So biomechanics is very important. I did that in my last lecture, talk about osteotomy and how we plan osteotomy. We need to make sure the mechanic is correct. And I'm just going to briefly touch upon this. I'm not going to go too much on it. But biomechanics need to be correct first before the other things can follow. So let's focus on the cells. So what cells do we need? Really, there's only one. It's chondrocyte. We talked about stem cells before, and actually they're not really stem cells. So the only cells that we know in the mankind that can produce cartilage is chondrocyte. Yes, so we get chondrocyte. Where should we get it from? We want autologous. We get it from ourselves. So how can we get these chondrocyte? So these chondrocyte are trapped into the extracellular matrix, the bit that the white bit they live in. So we want to actually free them from this environment. We want to jailbreak them. So we want to free them from the jail and then want them to do work. Once they come free from the jail, they can start do work. So they're ready to build. Now, so we got the cells. What should we do next? We need to get an incubator. We need to get an incubator that will monitor our temperature. We want to monitor the oxygen. We need to give the right environment. We want to give everything correct. And how can we do that? And there we go. It's just right there in front of us. It's actually in our own body. We actually, if you really think about it, our human body have done it once. We have grown cells before. My mother have grown me. We have grown cartilage before, and this is the best way to do it. We should incubate things within our own body if we can, and our own environment within the knee will take care of itself and actually will monitor, will do our fluid balance. Now, and then we also need to give these cells the raw material to start building. And how can we do that? So what do we know they like? We know they like collagen. We know that they like hyaluronan. So we want to choose a membrane. We want to choose something that will be useful for these cells to use. For example, the typical membrane that I use is chondrocyte, which is a collagen membrane, or we can use hyalofast, which is a hyaluronan type membrane. So this will provide the cells some raw material. And then after that, we want to talk about the nutrition and the way that we want to direct these cells. So you can put a bunch of builders together, but if you want this builder to work efficiently and work in a team to do things quickly, we need somebody to tell them what to do. And do you remember what we talked about earlier on about the stem cells? Although they no longer call stem cells, what are they really? They are medicinal signaling cells. They are the managers. So we want some of those. We want some of these managers to go in there to manage and tell these builders how to build their material. And also, we need to give them some incentive. We need to give them some signal and tell them how to do it. And how do we give signals within the human body? We give drugs, right? So we need a massive drug store in order for us to tell these cells what to do. And remember, the medicinal signaling cells are the human drug stores. So we need to use some of these cells to try to help the body to regenerate. So let's not forget, if we respect this biological barrier. We will respect the biological layer, and we think about, we use things based on principle, and we actually work with the regenerative theory. Things should grow. So this is a case I'm going to talk about. I have done with the single stage treatment, the STACi treatment. And then just quickly go back to that. That's the principle. So this person, we have done the alignment correctly. I have checked his alignment; it was correct. So really, we just need to focus on the three things: the cells, the growth factors, and the scaffold. So here we go. This is I got my technician to come into the lab. The lab to come into to the theater, and we actually do everything there at one go. So this is my scrub nurse, and then when we're doing the operation, so we open the knee up, and then we found this defect within the knee. So it's 2.5 centimeters square, quite a big defect on the lateral side of the knee, and this is a 40-year-old gentleman. So it's not suitable for knee replacement, and this is why we go in the biological route. So we curate and collect some of the cartilage from the non-weight-bearing area, from right on the side of the knee, and then so there you go, we remove some of the right at the side, so it's not loading on that side. We chopping these cartilage up, like how we do it in the lab. We chop them up and then we digest them. We put them into enzyme digestion. So we digest these cells. So that's the bit I'm talking about. We gel break them. And then we also need to take some bone marrow aspirate from the knee, or we can take it from the hip if we wanted to. You can take it from superior, inferior, anterior iliac spine if you wanted to. However, because we are operating into the knee, so this is the easiest place and closest place to do it, instead of giving the patient a separate scar. So we got the cells from there, and then we process those cells, and from that, what we're interested in is the medicinal signaling cells. From this, we process them, and then we put them together. So this is the bit that we enzyme digest the chondrocyte, and then after that, we centrifuge to get the right cells. And then we only end up with a very, very small cell palette. We look in the microscope, make sure we got the correct cells. And here we are. This is what a photo through the microscope. So we got those cells. And then the next thing is about the scaffold. While we're doing that, we can prepare the scaffold. And then with this is just templating where the scaffold is. And then with that template, we can then cut the real thing. So that's my final cell quality. And then here we are. We're putting the cells onto the scaffold to soak into that scaffold, and then we stitch that scaffold onto the knee, and then we put some glue to seal the corners. And then after that, I always use this brace. This is called the rebound and loaded cartilage brace made by Ossa, and that is something to protect that area. On this specific case, we are offloading the lateral condyle. The important thing here is that because I'm using the human as the incubator, I need to also provide them some mechanical load for these cells for them to grow in a certain way. If I don't load these cells of a non-weight bearer, that patient for let's say 6 weeks for these cells to grow, and the moment that when patients start walking, the cells will start to disintegrate because they don't like the environment. So this is why I use that brace to actually offload most of the weight, so that will reduce the weight going through there to up to 80%. So they're only having 10 to 20% of weight going through that, and that's really useful too. And patient can start walking, start mobilizing immediately. So this is before. This is what happened in surgery, and that is the MRI scan. So pre-op, so you can see there is a area there, and then that's 3 months after MRI scan. That's 12 months, so you can see the defect has filled up. So that's before and after, so you can see the defect have filled up. And also I have the opportunity to go back and look at that defect, and that filled up with some cartilage. So here we go. This is and also we take some scores as well for this guy. Before the operation, his Leishman score is 36. Now at 12 months on, his Leishman score is 96, which is back to normal, which is very good for 40-year-old man. He went back to running. The reason that I had to rescope him is because he went back to play football, and he done his medial meniscus, and we just have to trim that. But at the same time, we had a look at it. So here we go. And the important thing for the future is that I think we need to start augmenting these repair with more of the PRP as well, because when we talk about the principle of the cells, there's evidence show that the more more interval of PRP that we give when we're doing cell regeneration, the better quality of cartilage that it will give. So it's something that I'm going to continue to do and continue to build in the future. So there we go. That's the end of my talk, and here's my contact details, and happy to take any questions. Thank you.
Thank you very much, Professor Lee, for this compelling presentation. It's very easy to follow logic for something really complicated. As far as I'm concerned, I understood everything, although I'm not from the specialty. And also thank you for challenging those existing methods, which maybe don't make so much sense. So let me check with our participating hospitals if we have any questions. May I ask our technical management to unmute Changzhou Hospital, please? Thank you. Okay, Changzhou Hospital. Hello, do you have any questions for Professor Lee? Let's take some time. Hello, Changzhou Hospital. Do you have any questions? Maybe the session is up, man. Constance, may I please ask to move to the GCR Hospital? Hello, GCM. We did have a nice picture of the audience before. Hello, GCM Hospital. We've lost you. Hello, GCM Hospital. Well, maybe I should ask questions. Hello, GCM. Do we have you on the microphone? I will send them a message. Let me ask you a question. How did you, because I saw you were commenting on all these chemicals that are in the normal culture. How did you come to the idea that all of this may not be working? Because, I mean, now when you're explaining this, it's kind of making sense, but to come and challenge this thing that everybody's using, what made you and your colleagues come to the idea that this is not so good?
Sure. Yeah, I mean, that is an interesting question. I think I was challenging these concepts when I was working in the lab, when I was working with Professor Richardson with his scientists, and to say, why do we use, this pink solution? Do we actually know what is in it? Nobody does, but the important thing is that this is the published cell culture method, and we have been doing that for a very long time, and that's how we get results. I think that's good. That's one way to do things, but at the same time, if you go back and really think about things, it doesn't really make sense. I think back 30 years ago, it's very important to do that, because besides that, there's no other ways. But now, as technology advances, we have better understanding. We now able to actually bring the lab to theater. I mean, 30 years ago, you wouldn't imagine that, because we don't know enough about the cells. We don't know enough how to process them efficiently and quickly. Now we do. So I think it just the way the technology have catch up, and we will be able to do this technique, and we can think a little bit more and challenge what we used to have than actually just carry on and just copy what the literature say or what the textbooks say. I think this is something that why I start challenging it, and I think the technology is there, and that's where this is why it's exciting time. Oh, yes, your microphone is off. Sorry, what do you say?
Is my mic okay?
There you go, back now.
Yes, I'm back on. Brings us to the very important message that we should be reviewing all our approaches and try to rely more on nature and less on chemistry.
Absolutely.
Okay. Let me just check again if we have any message from TCM, because I can see that there is probably a microphone issue. Hi, TCM Hospital. Do you have any questions for Professor Lee?
I had the message from TCM that they don't have any questions.
Okay. So maybe they're shy today, and maybe we can get some questions in writing. This is a very interesting topic for the current stage of cartilage management. Where do you see the future, Professor Lee? Where are we going from here? What's next?
I think this is a very good technique, and I think things that can be done in one sitting and saving the patient further operation is always good. And I think this technique will be more popular, and actually it's not something that we rely on a lab. So all we need to do is we can actually do this technique anywhere in the world. We can just go to, I operate in London, I operate in Lincoln, and then my team can actually go anywhere in the world to be able to operate it, to do this technique. And I think that is very important. And I think in terms of what I'm saying in the future is that we want to further improve the quality of the cartilage within that growth, within our regeneration technique. So I think the platelet-rich plasma and the higher you run on it will become more important over the next few years.
Yes, and it's incredible that some recognition has come from NICE, which is extremely difficult, as you said. So the road is paved to be able to practice this much more with less restrictions and less opposition, right?
Great. Yes, that's correct.
Okay. Thank you very much for this. I don't think we have any questions today. So let's ask our audiences to give us written requests and inquire offline if they wish to know something. What's our next topic for next time?
I think we're going to talk about 3D custom knee replacement next time. We're going to move a little bit away from the regeneration. We talk about the 4 different principles. We can come back to it in a few months' time on that. But I think the next thing I want to talk about is the latest technique in knee replacement.
That's wonderful. Thank you very much for your presentation today. And I'd like to say bye-bye to our audiences at Changzhou Hospital and TCM Hospital. Thank you very much, and have a nice day.
Bye-bye. Bye-bye.
Bye-bye.